Hey, what's going on, everybody? I went over our first hands-on, basically special test over the ankle. And what I like to do, guys, once we get hands-on with this, I like to give you the special test first, and then I kind of want to discuss most of the practical injuries that you're going to see. Again, this is the principles of athletic training. So I wish that I could sit there and make it a whole semester of just lower extremity. But if you get into like PT school or PA or athletic training, you'll have that. So I'm basically giving you the crash course. But again, I want to make it practically and things that you will most likely run into on a daily basis if you do go into this. If you don't, it's still kind of nice to know that you can basically evaluate some of these injuries if it ever happens to either a family member or one of your friends. So if you want to pull up the PowerPoint real quick, I'm on lower leg injuries, and we're going to start off. If you guys can remember me saying the first thing that you ever want to rule out is a fracture. I want you to remember that, write that down. Yes, it will be on the midterm and everything, so make sure that you rule out fracture first. I do not care if they have a sprain, a tear, an Achilles tendon rupture, whatever it is. If you see a visible fracture or that bump test is positive, everything else goes out the window, and you make sure that you document it and get basically they get referred to the proper channels. Okay, send them to the ER, splint, and send per first aid. Okay, so when we're looking at fractures, I have on here tibia and fibula fractures. I want you to understand that the tibia is the most commonly fractured out of both of them. Okay, it is because I wish we were in class because I'd ask you guys, but it is because it supports 90% of your body weight. Okay, the fibula only supports about 10%. Sometimes when people break their fibula, if you've ever broken your fibula, you can actually come back and play if it's not displaced within 3 weeks faster than if you were to break a tibia, and that's usually season ending. Okay, so again, because we don't have a lot of meat around or muscle around basically that bone, it is usually injured because of direct trauma, all right, rather than indirect trauma. It's very rare that you'll see somebody break a tibia just non-contact, but it's happened. I do have Kevin Ware on here, that YouTube. Again, it's graphic. If you guys want to look that up, I'm sure you've seen it before. You can look that up. That is a textbook non-contact tib-fib fracture, which is actually open, so that's really bad. But what I like to do is I like to give you the signs of injury that was given to me in undergrad, and I give you all this stuff, but nobody ever told us how to take care of it until later on. So I do want to give you a little bit more background on that. So your signs of injury, anytime you're looking at any kind of fracture or bruise or contusion, when you're looking at any of these bony injuries, is you're going to have obvious immediate swelling, okay? Definitely some possible deformity. You can actually see, you don't have to have x-ray vision because you can actually see that, hey, I think there's a fracture there. It's obviously displaced. And then you can do the bump test, or there's pain with palpation. Palpation means that you are touching around the area where they say it hurts. If you've ever been to the doctor's office and they're like, hey, where does it hurt? You're like, right here on my ankle. And they go, like that. And you're like jumping out of the chair. That's why they do it, because they're trying to pinpoint exactly where it hurts, and they basically trying to localize it. Okay, so those are your signs of injury, which you most likely, when I'm covering a game as an athletic trainer, you want to make sure that you're not doing like a 20-minute eval. This should all be done within 30 to 45 seconds. We call it triage. You're triaging the injury, trying to figure it out. That way, one, the athlete is not suffering. You can get treatment done real fast, and then you're making the decision of whether they can go back in the game or if this is actually a fracture, and you are basically going to refer them to the ER and use the proper channels that way. So, if we do suspect a fracture, what is our care? Immediate splinting. You want to splint above and below the fracture site. Make sure that that is where it's at. That goes back to basic first aid, guys. Okay, so it's like make sure that first aid is kicking in. I also like to check the distal pulse before and after. The reason why is because I don't want it to be a serrated fracture where it compromised an artery and they don't have a pulse, and all of a sudden they're not getting any blood supplied to their ankle or their foot, because within 30 minutes and an hour, basically no blood, that means your muscle tissue starts to decay and it can actually die. Okay, so we don't want that. I also check it after I splint, so I'm not cutting off any circulation. Okay, so it's like you want to check the distal pulse before and after. That distal pulse can be found behind your lateral malleolus on your ankle. Okay, so if you want to put two fingers, you find your lateral malleolus, and then you just go back about an inch. That is your distal pulse right there for the foot. Okay. Definitely some ice, that's just for pain control, and then obviously refer to the emergency room, and you got to get an x-ray because you don't have x-ray vision. And I have up here the YouTube link for the Kevin Ware injury. Guys, that was my best friend who was actually one of the athletic trainers for Louisville at the time. I don't wish this upon anybody. I mean, that was really bad. He made a good recovery, but it was really terrible. And it was also really terrible for all the bystanders and everybody that saw it too. It's just a freak injury. Again, if I was in class, I'd go in more detail of why it happened, and we'll get to that later on down the road. But so that is basically fractures in a nutshell, all right? The next one, if you've ever had stress fractures before, again, guys, these can happen, but you can't remember what I said during our fracture lecture. You cannot look at it on x-ray. So now I'm on stress fractures. Again, it's a higher rate of occurrence in the tibia because it takes about 90% of the load. It's repetitive loading during training, conditioning, or games, all right? It doesn't matter which sport. Most of the sports, depending on, is your jumping sports. So you got volleyball, you got basketball, but you can get basically a stress fracture with any sport if you just can't have competitive or repetitive loading in whatever you're doing. Okay, so it's like me as an athletic trainer, when somebody comes in and they start having like dull back pain or dull like leg pain and it's not bilateral, I start thinking of that in the back of my mind as a differential diagnosis. Okay, so you want to make sure this can be related to a couple different things. So shoes, maybe biomechanics, maybe they have some bad biomechanics, whatever sport-specific activity they're doing. If anybody's ever done track before or cross country, you know that surface change is a huge thing, and obviously repetitive jumping. So it's like any of these factors, like look at it, take a good history, see if you can link it to anything like that before all of a sudden you just start saying stress fracture, okay? Again, usually stress fractures, these happen if an athletic trainer is doing their job and the athlete's actually being a good athlete and coming to you and letting you know. These should never happen. But again, these do happen, so they slip through the cracks. I want you to understand that usually the signs of injury with this, because this will be a test question, pain up the shins, and it's going to be during and after activity. So once they go home, it's still going to have an intense pain. They're going to be hurt, and they're going to be complaining, man, either both of my legs or my lower leg or one lower leg, not depending on which dominance they are, is going to just be killing them all night long, okay? And it's usually 3 to 6 weeks after or during current activity, okay? It just doesn't pop up. It usually takes 3 to 6 weeks for a stress fracture actually to happen. You might see some localized inflammation and then point tenderness and palpation. If you've ever had a tuning fork put on you during an evaluation from either a PT athletic trainer or somebody at the clinic or something like that, it's not going to be your friend when you have a stress fracture. They jump off the table. Again, if you think that there's a stress fracture, refer to the physician first. They're going to order up a CT scan, light you up with iodine, that way they can see it better. It will not show up on x-ray, like I said, and I want you to make sure you shut them down. Stop activity, put them in a boot if you have one, or just get them on non-weight bearing as soon as possible until that CT scan comes back. And then some ice just for some pain control and comfort, okay? Here I have an x-ray. It shows you exactly where the stress fracture is in this tibia. And then I want to get into shin splints. Usually I always used to say shin splints first, then stress fractures, but I wanted to give it to you backwards, okay? Because usually shin splints will happen at the beginning. If you've ever been a runner before, have ever dealt with runners, you know that it's super hard to try to shut down a runner, okay? It's insane. It's like, hey, don't run. Well, that's what they do. Some people love it and some people hate it. And if you love it, I understand. That's how you either release stress, that's your sport, whatever it is, okay? What I try to do is compromise, okay? Because most people, especially in high school, or if you haven't already, you're going to find out that shin splints suck, they happen, it hurts, and you want them to go away as soon as possible, okay? But for serious runners, if they start developing shin splints, they know that it's either time for a new pair of shoes, there's either a change in the weather, or they've been changing surfaces, but you want to take care of it, but I never try to shut them down. I try to compromise. Let's say for the next 2 days we try to get on the bike or the elliptical or something non-weight bearing, maybe a pool exercise if a pool is available, just so this can heal up so we don't get into stress fractures, okay? So again, there's a lot of different theories behind this about the cause of injury. The new theory now is a strain to the posterior tibialis. So if you actually look at it where the origin insertion is, it actually originates from the medial part of your tibia and then goes back around. So just like with any other tendon, it can develop tendinitis and going to start pulling on the origin, which theoretically can cause medial tibia pain, which is medial tibial stress syndrome. By the way, guys, some people, especially some orthopedics, they don't like the term shin splints. It's a layman term. They like the term medial tibial stress syndrome, okay? That's how you're really supposed to say it. Just for the time being in this class, I don't care if you say shin splint. So it is what it is, okay? Again, just like with stress fractures, change of surface could be a cause of injury. Poor biomechanics, change of shoes, and change in weather, what I just said, all right? Now, the signs of injury, again, it could be bilateral, it could be on one leg, it could be on the other leg, whatever it is. This is where it differentiates from a stress fracture. One, it's not going to have a lot of localized inflammation, and number two, it's going to hurt during activity, but the pain is usually going to stop after activity. That's how you know, okay, this is what we're looking at. I don't need to freak out yet. We can easily take care of this with some ice, maybe some NSAIDs per guidance. Okay, just make sure anytime you give recommend like ibuprofen to somebody, say per directions, all right? Depending on who they are, you can stop activities for a few days. I don't recommend that. I want you to always go conservative, but again, just for the time being in the book, I want you to say stop activity for a few days, okay? And then you can do different strengthening techniques to strengthen that posterior tibialis. Compartment syndrome. This is something that nobody ever talks about. I've seen this too many times in my career, so I want to make sure that I basically give you guys just a heads up on it to put in the back of your head anytime you do see this. There's two different types of compartment syndromes, acute and chronic. If you have not had anatomy yet, your lower leg is basically, look at it as a PVC pipe. Okay, it's a PVC pipe and it's got 4 different compartments. It's got an anterior, a lateral, a medial, and a posterior. Okay, different tendons, different ligaments, different arteries, different nerves run down each compartment. The thing that works against us as we stand bipedal or in an anatomical position is gravity. Our blood flow just goes straight down and then it's supposed to come straight back up, okay? Sometimes because our tibia or our lower leg is exposed because it does not have a lot of muscle surrounding it like our thigh, basically those compartments are exposed. So when it starts to swell, that swelling has nowhere to go. So it starts compressing on these tendons, on these arteries, on these nerves, which can become life-threatening, okay? So acute, most of the time, it's usually like when a baseball player or softball player takes a line drive to the leg or something like that, and it just starts swelling up and your skin has nowhere to go and it looks like it's going to bust, okay? This compromises, again, the lower leg, the ankle, the foot for blood supply and can also cause deterioration in those muscles, all right? Just like I said. So you're going to have immediate swelling in the lower compartment where the acute injury came from. So let's say you took a ball to the medial side of the leg, that's where it's going to swell at, all right? Other signs of injury is numbness in the ankle and extreme pain and tightness. Guys, the volleyball player that I saw this happen to, she almost passed out because the pain was so bad. If you've ever had this happen, I want you to email me and tell me how you handled it, or if you've ever seen a friend or something like that, because this is super serious. So that is acute. Acute meaning it happened right then and there. Either a ball hit you, somebody kicked you, whatever it is. Chronic means it happened over time. So again, take the stress fracture, repetitiveness of the lower leg. All of a sudden your tendons create tendinitis. You're going through volleyball practice 3 times a day for an entire 3 weeks, and your tendons just basically start bleeding out on all themselves. Same thing. It's still compartment syndrome. It doesn't have to be a blow to the lower leg, but that swelling has nowhere to go. Same issue of how we're going to take care of it, okay? This is immediate referral to the ER. You have to ice the entire leg, try to get that swelling down as much as possible, and obviously elevate. I want you to check distal pulses. You don't have to splint. If you feel like splinting, that's fine. It's not going to do anything wrong, but just make sure you elevate, ice, and get them to the ER. They're going to do something called a compartmental release, in which I have pictures here. Now, one of these pictures is basically, it looks like petrified wood, and it doesn't matter what color your skin is, too. I mean, it's just going to be really shiny and gross. But anyway, I wish I could have more time to tell you my stories of compartment syndrome. But basically, I thought it was going to be all scientific. I'm in the OR, and I'm watching this happen, and all of a sudden, he just, orthopedic doc takes a scalpel, and he goes, everybody ready? And then he slits, basically, a slit right where the compartment was swelling at. Blood goes all over the table, and then he sewed her back up, and he's like, yep, there you go. I was like, okay, well, that's pretty not scientific at all. If you guys want to get on YouTube and see this, there's a lot of blood. It's very graphic, but it's literally, you just release the part of the skin openly to make sure that the blood has somewhere to go. Okay, so it's not compromising any of those tendons and nerves or anything like that. So, and your last one, Achilles tendonitis. I want you to realize that the Achilles tendon is the largest tendon in the human body. Okay, anybody that's ever had Achilles tendonitis, it is super ridiculously aggravating, okay, but it can be fixed, all right? can be fixed. If you have an athlete that really wants to sit there and get better, and they do this, this can literally get fixed in like 48 hours, okay? But your cause of injury is running, jumping, and repetitive stress with plantar and dorsiflexion. Usually if somebody's either out of shape or you're running a lot of uphills and downhills and stuff like that, it's going to happen on the dominant side, all right? Your signs of injury, obviously, they're going to be complaining of pain along the Achilles tendon. You can palpate your Achilles tendon, and then pain with dorsiflexion. And they're also going to be walking with an abnormal gait. They do not want to dorsiflex, okay? Anytime you dorsiflex, that means that that tendon's basically on stretch, all right? Your care, stretching protocol. Anytime somebody comes complaining about any kind of Achilles tendonitis, make sure that they're stretching before and after activity. You can stop activity if it gets too bad and you can see some visible swelling, ice. But what I do, guys, is I just get some $1 felt, maybe a half an inch, and you can put little heel lifts in their shoes. You just cut out like a little heel, put it right in their shoes, or they can go to Walgreens and get lifts to put in there. I think it costs like $10, and it usually should take care of itself within 48 hours, like I said. And your last one, Achilles rupture. Honestly, y'all, I think the Achilles rupture is worse than an ACL tear. I've seen too many of these, and it's a lot of the weekend warriors. And I have up here, guys, I want you to pay attention. Girls, I'll get to you when we start talking about ACLs. But guys, for right now, men over the age of 35 have a 60% more likelihood to tear their Achilles tendon, all right? A lot of this weekend warrior stuff, guys will try to get out there and try to pick up a game of basketball, and they haven't played in 10 years. They're not stretching properly. Maybe they're overweight, and then all of a sudden, boom, their Achilles tendon just snaps. And it's literally, when it snaps, it acts like a fruit roll-up, and it will roll into your calf. They got to go up there with a hook and fish it back down and then reattach it, and then you're in a boot for the next 6 months, and then you've got PT after that. So it's a pretty grueling surgery. So your cause, cutting or jumping in a rapid motion, a lot of times landing after jumping, or extreme dorsiflexion. Your signs, deformity, okay? What I mean by deformity is you're going to still see a canal of where the Achilles tendon is, but if you palpate it, it's just going to feel squishy. Achilles tendon's not in there, all right? Loss of function, that means it's not doing its job anymore. Its job is to plantar flex the foot, so it's not going to do anything. It's sort of like the Thompson test, what I showed you in that last lecture, and then immediately swelling and like I said, positive Thompson test. I like to refer them to the ER just to make sure that when it does roll up into their calf, that it's not cutting off any nerves or any kind of arteries or things like that. Splint, obviously you're going to check pulses just like the other stuff. You can use your Rice principles, and then it's going to take surgery required if they ever want to walk again. So I have a picture here. This is what it looks like, a normal Achilles tendon versus a rupture. Kind of looks the same. You still see the canal. You can see some obvious swelling here, but other than that, guys, that Thompson test. I've never really heard of a lot of people in agonizing pain whenever they have. I've seen about 15 Achilles tendon ruptures, and all of them are literally confused. They all look like a sad puppy because they know something really bad happened, but they can't figure out what it was. But other than that, guys, that's all I have for today. If you guys have any questions about this lecture, obviously feel free to email me if you guys have any injuries which I talked about, either whether it was you or a friend or something like that. Email me, and then I will see you guys next time. We'll go over the knee.